All right, this is your video on rate and regularity, step one of the disciplined approach to 12-lead interpretation. My name is John Carrico. This is Pulse Education. Thanks for joining us either for the first time or coming back to the channel. Happy to have you along. Last week's video, we talked about and really stressed the importance of having a disciplined approach to 12-lead interpretation. That in doing so, we're not going to miss anything. And if we miss something, we know that potentially we can either misdiagnose, underdiagnose, overdiagnose our patient. And we don't want to do that. We want to be right. The other thing that we're going to see that having a disciplined approach is going to do is it's going to allow us to not be intimidated by the 12-lead. Because sometimes we can have a 12-lead that is very complex. And we need to break that apart so that we can interpret it correctly the first time. And a disciplined approach is really going to help us do that. And today we're talking about rate and regularity, step one. All right, so just as we say in the step, so the first part is going to be rate. All right, so immediately when we get that 12 lead, what I want you all to do is I want your eyes to go specifically to the rate that's written on the 12 lead. And what we're trying to determine is the rate too fast? Is it a normal rate for the patient, or is it too slow for the patient? And then we're going to make some determinations from that. All right, so again, as soon as our 12 lead comes up, the first thing we're going to find on that 12 lead is where the rate is. In this case, we can see we have a rate of 79 beats per minute, a normal rate. Okay, but that's not always going to be the case. So that's what we're going to do. We're going to determine, we're going to look at the rate, and we're going to say, is this too fast, is this normal, or is this slow? So what do we get out of it determining whether or not this is fast? Okay, well, a couple things that are really important, okay? The first is that we know that when the heart rate is too fast for our patient, meaning the heart is not able to actually compensate well enough based on the demand put on the heart, is that we can actually have some rate-induced ischemia. Okay, so the heart is actually having a little bit of ischemia, a little bit of hypoxia, if you will, because it's simply beating too fast in comparison to the health of the heart. And so that can cause this rate-induced ischemia, where we can see ST depression, even ST elevation, but it's not there because of coronary occlusion. It's simply there because the heart rate is too fast and the heart can't compensate properly in terms of its own perfusion. Okay, so what that usually means is all we have to do is slow down that rate, and as we slow down that rate, we're going to see that ST depression or ST elevation start to disappear, okay, because the heart can actually compensate. Okay, another thing that we see that most commonly with STEMIs, right, with our ST elevation MIs, with our coronary occlusions, that most of the time our heart rates are not intrinsically greater than 130 beats per minute. Even greater than 120 is not commonly seen, but certainly greater than 130. And so if we have a patient that we're concerned is an acute coronary syndrome patient and their heart rates are higher than that, we really need to figure out a way to slow that rate down somewhat before we're determining whether or not this patient is a STEMI patient and needs to be going immediately to a cath lab. All right, so we need to think about ways in which are proper for this patient to slow that rate down some. The other thing that we can think about is in terms of VTAC, that most of the times with our VTAC, we're going to see rates in that 120 to 180, maybe even up to 200. And so by determining if this rate is fast, it may help us determine whether or not this patient is potentially in VTAC, okay? And then we have our SVT, okay? So with SVT, that's really based not necessarily on greater than 150 beats per minute. What it's really great based on is the age of the patient. So one of the kind of the formulas that's out there that most cardiologists refer to is going to be this idea of 220 beats per minute minus the age of the patient really gives us the baseline for SVT. So if we had a patient who is 60 years old, okay, so and they're having chest pain and we put them on the cardio monitor and we do a 12 lead. If that heart rate we do 220 minus 60, so that's give us 160 beats per minute. So that 160 beats per minute is really the lowest threshold for whether or not this patient can be an SVT. Vice versa, if we had a 20-year-old patient, right, then in that case, 220 minus 20 gives us 200. And for a 20-year-old, 200 is really that lower threshold for whether this patient's in SVT or not. So you can see the benefits all right, of determining whether or not this rate is too fast for our patient. And really, again, what we're going to probably do is treat the rate first in terms of before we decide whether or not this patient actually has underlying ischemia. And then we have to think about if the rate is too slow. And typically slow rates are going to be less than 50 or 60 beats per minute, all right? And the first question we have to answer is this normal for the patient? Because we know that for some patients, that can be completely normal. They can have a very low resting heart rate, okay? The next question we have to kind of think about is, what's the etiology behind this? Is this a simple bradycardia? Meaning, is it simply, this is a normal looking rate, but it's slow, okay? Which still can be problematic for our patient, but it's not complex. Versus, is this potentially a conduction problem? Are we seeing a conduction block, a second degree or third degree block? Is this a ventricular escape rhythm, right? So we need to kind of determine and really kind of triage why this rate is that slow, all right? So rate is going to give us a lot of information for our patient and really help us determine how we're going to treat our patients. So here's a great example. We've got a 12 lead on here. If our eyes went straight to looking for ST depression or ST elevation, we would find it, okay? But we're not going to do that. The first thing you're going to do is your eyes are going to immediately search for that heart rate. If we do that, we can see the heart rate's 170 beats per minute, okay? This is an 83-year-old patient. So an 83-year-old having that fast of a heart rate certainly could warrant chest pain, could make them look like acute coronary syndrome. And so we can already know, though, that rate is far too fast, okay? So what do we need to do? We know that we need to slow this rate down before we try to determine whether this is an underlying ischemia, okay? Most likely this is a rate-induced ischemia, and we need to figure out the cause behind it. So our next step of rate and regularity is regularity. So we're just determining, is this regular, is this irregular, or is this completely irregular, okay? So regular kind of speaks for itself. Our irregular rhythms, what's causing that, right? And most of the time we can kind of look on the 12 lead and see that, yes, there's some regularity in this rhythm. However, it seems like there's something that's causing this to have some slight irregularity. Oftentimes that might be ectoby, it could be a conduction block. The nice thing though is that V-tach is not an irregular rhythm. We don't see irregularities like that. So that can be a very comforting thing. We may not know exactly what the rhythm is or why it's irregular, but if it is irregular, chances are that this is not V-tach that we're seeing. And then finally, we have completely irregular, all right? And our completely irregular, meaning there is absolutely no regularity between any of the complexes. Usually what the most common thing that causes that is atrial fibrillation, right? Or an underlying atrial fibrillation is the cause of that. The other nice thing again is that it rules out V-tach, because V-tach is not going to be completely irregular. So let's take a look at some examples. So we have our 12 lead here. The first thing you're going to do is your eye should immediately go toward the rate. And we can see on here our heart rate is 92 beats per minute. So that's a normal rate, not too fast, not too slow. And then we're going to look at the regularity. If we march out our complexes, we can actually see that this is a completely irregular complexes. The rhythm is completely irregular, and so most likely we're dealing with an atrial fibrillation. Now, one helpful hint is that we can do to kind of confirm this a little bit is we can look at our PR interval. Our PR interval is the 12 lead measuring the distance between the P wave and the R wave. Now, in this case, it's unable to do that, and that's usually because the 12 lead is unable to pick up a P wave, all right? So we also know that in atrial fibrillation, oftentimes there are no discernible P waves, or they're certainly not ones that happen on a regular basis. So looking at that, most likely, again, we've got a rate of 92, it's completely irregular, so we're probably dealing with an atrial fibrillation. Our next one here, we've got our first, again, our eyes are going to go straight toward rate. We've got a rate of 86. We march out our complexes, and we've got a regular rhythm here. So normal rate, again, we can look for ischemia. We don't have to slow the rate down. We know that's not too slow, and we've got a regular rhythm here. Another one here, right? immediately, hopefully we've got you in a nice disciplined approach now. First things first, we look at rate. We've got a heart rate of 130 beats per minute. So we're getting into that. This may be too fast. One thing we certainly know is that it's probably too fast for this to be a STEMI, that we just don't see patients having STEMIs with heart rates of 130 beats per minute. So we've got that fast rate, and now we need to look at, is it regular or irregular? And as this marches out from complex to complex, it's actually completely irregular, right? And we said most likely with completely irregular, we're dealing with an atrial fibrillation. In this case, with the heart rate being 130 beats per minute, most likely this is a atrial fibrillation with a rapid ventricular response, or RVR. Next 12 lead here, eyes go straight toward the rate. We can see here a rate of 112 beats per minute. Now, typically speaking, that's not too fast. It's certainly not too slow. It may be even somewhat normal, but it's not too fast. We can still determine whether or not this patient's potentially having ischemia later on in our steps. But we certainly know that that rate's okay. Then we're going to look at our regularity. It marches out in a regular rhythm, a regular distance between complexes. So we're dealing with a sinus tachycardia here. It's regular. We can carry on to our next steps. I mentioned one of the things that of having a disciplined approach, what that can help us do is when we have really complex or really kind of ugly looking 12 leads that can be a little intimidating, that it's going to help us break those things apart. We're going to be able to kind of break them down and rule some things out and rule some things in. So looking at this 12 lead, that's a pretty ugly looking 12 lead. And if it's our responsibility to make life-saving decisions based on this patient's 12 lead right now, well, we want to feel confident with that. So again, first thing we're going to do is look at the rate. We can see the rate is 157 beats per minute. So that's pretty fast. It's too fast, right? Certainly too fast to determine whether or not this is ischemia, but certainly there's a number of causes in here. Is this an SVT? Could this be a ventricular tachycardia? So there's a lot of different things here, but certainly the rate is too fast, all right? So then we look at the regularity. And if we march out these complexes, we start to see that this is actually an irregular rhythm, that it's actually somewhat completely irregular in there. There's not, even though it may look like it from afar, it's actually completely irregular. So one of the things, we don't know exactly what the rhythm is, but what we can rule out is that this is not a ventricular tachycardia because it is an irregular rhythm, all right? We're going to learn more about this 12 lead, obviously, as we go along. We'll be able to, as we go through our steps, but right now we know that what we're dealing with a little bit. And then lastly, I put up this last 12 lead because if any of us have any background or any previous knowledge of STEMIs and ST elevation, then you're certainly going to be able to recognize that right away, yes, this patient is having a large infarction. But again, what we have to train our eyes to do is immediately go through our steps. So you need to go toward rate, right? So we look at our rate, and this person's rate is 51 beats per minute. So again, is that normal for this patient? Is this a simple bradycardia, or could this be a conduction block? And in this case, if we march things out, we're going to see that one, this is actually an irregular rhythm, right? So we have a slow rate, it's irregular, and looking at this, this patient's actually in a third-degree heart block. So that's hugely important for us to determine early on in this patient, rather than just going, yeah, this patient's having a STEMI, let's immediately start doing the STEMI care. No, we've got more than just a STEMI here. We've got a patient whose heart is very sick right now, whose rate potentially is not perfusing the patient well enough, and it could get worse. So we need to be paying attention to that, and that's why it's so important that we do this step-by-step approach to interpreting our 12 lead. Okay. So again, I think hopefully we're driving this home, why it's so important to have this disciplined approach. This is just step one, rate and regularity. We're looking, is it fast, normal, slow? Is it regular, irregular, or completely irregular? Awesome. Well, thanks again for joining us this week. Hopefully this is helpful. Please put a comment below in the comment section. If you have a question, we'll do our best at answering some of those questions. Like, subscribe, come back and see some more videos. Thanks for learning with us today.